We've got another great issue this month, beginning with a really exciting article on finerenone in heart failure with mildly reduced or preserved ejection fraction, where we will be talking with one of the authors. Then we will be discussing an article from Diabetes Care on comprehensive multiple risk factor control in type 2 diabetes to mitigate heart failure. Then, an article from Lancet Diabetes and Endocrinology on the efficacy and safety of once weekly semaglutide 2.4 milligrams versus placebo in people with obesity and prediabetes, the STEP 10 trial, followed by a discussion of an article in Diabetes Care on diabetes, prediabetes, and brain aging, a fascinating area. And then we will conclude with a discussion from one of the authors of an article in Diabetes Care on sitting time and its interaction with physical activity in relation to all-cause and heart disease mortality in U.S. adults with diabetes. For our first article this month from the New England Journal of Medicine, we will discuss a truly groundbreaking article, finerenone in heart failure with mildly reduced or preserved ejection fraction. This is a critically important article because this year's standards of care, the ADA standards of care published in Diabetes Care in January, which we've discussed on this podcast in the past, recommended for us to consider screening adults with diabetes for early heart failure. So this has a lot of relevance. And joining us to discuss this article is one of the authors of the paper, Dr. Muthu Vaidyanathan, who is a cardiologist and co-director of the Center for Cardiometabolic Implementation Science at Brigham and Women's Hospital. He is faculty at Harvard Medical School. Welcome, Muthu.
Neil, thank you so much for having me.
Let's start with the background for the study. Can you give us a sense of why this study was undertaken?
Thank you. So this study was undertaken in a population of heart failure with mildly reduced or preserved ejection fraction. And this HFpEF cohort has been traditionally very difficult to manage. And unfortunately, we've had very few evidence-based therapeutic options. The sodium glucose cotransporter 2 inhibitors were the first class to definitively show evidence of benefit and safety in this population. But even in patients already treated with an SGLT2 inhibitor, we see a great unmet need with high residual risk. And so there was great interest in developing new therapies for this high unmet need population. Finerenone is a non-steroidal mineralocorticoid receptor antagonist that reduces much of the downstream pathways that contribute to disease progression, like fibrosis, hypertrophy, inflammation, and of course regulates the renin-angiotensin-aldosterone system and early hemodynamic responses related to that. And so we felt that finerenone, because of its systemic actions, could actually potentially benefit this population that has traditionally been characterized as an older group of individuals with multiple morbidities, including diabetes and chronic kidney disease. Finerenone, as you may know, was previously studied in 2 large-scale trials of patients with chronic kidney disease and concomitant type 2 diabetes. That was the Fidelio-DKD and Figaro-DKD trials. That total program, encompassing about 13,000 individuals, showed that finerenone in that target population could reduce not only kidney disease progression, but also reduce cardiovascular events, such as heart failure events. And so because of the overlap between chronic kidney disease and heart failure, we too felt that this was an important compound to test in this population of heart failure with preserved ejection fraction.
That's such an important background that sets up for the why for the trial. Can you talk about the methods?
This was a large global trial of 6,001 participants conducted over a very many number of countries worldwide. Participants had symptomatic heart failure with New York Heart Association functional class 2 or greater symptoms. They had evidence of structural heart disease and elevated natriuretic peptides. These patients were randomized in one-to-one fashion to either finerenone versus matching placebo, and finerenone was titrated to either 20 milligrams or 40 milligrams based on the baseline eGFR. Patients were followed over time in an event-driven fashion, and median follow-up was 2.6 years. The primary endpoint of the trial was cardiovascular death and total worsening heart failure events that included first episodes of worsening heart failure, but also recurrent events of worsening heart failure.
Now, some of our audience may remember that in the SGLT2 trials, I believe it was hospitalization for heart failure that was the part of the primary endpoint. Here it was a little different endpoint. Are they roughly equivalent or are they completely different endpoints?
Very comparable, and it's an important issue. What we recognized, especially during the COVID-19 pandemic, was that many patients who traditionally would have been hospitalized for worsening symptoms of heart failure were being treated in the ambulatory care setting with even intravenous diuretics being administered. And so capturing the totality, the total burden of worsening heart failure was important, especially in light of this shifting landscape globally. And so Fine Arts Heart Failure selected a primary endpoint that encompassed not only hospitalization events, but also these urgent heart failure visits that may present in ambulatory care. And we felt that all these events, regardless of where worsening heart failure was being treated, was clinically important and reflected disease worsening by the patients.
Great, thanks for clarifying that. Let's go on now to the results. And when we talk about the results, I'd like you to go over the baseline characteristics with particular attention to the fact that our audience is primarily endocrinologists and primary care clinicians so that we can have a sense of whether the study is relevant to the patients that we see.
Absolutely. So 6,001 participants were enrolled and randomized in the Fine Arts Heart Failure trial. This was an older group of individuals with an average age of 72. Many individuals in the trial were well represented above the age of 80.
Hmm.
About 45% were women. Patients were enrolled across all global regions. About 70% of individuals had mild symptoms of heart failure, and then about another 30% had at least moderate symptoms of heart failure. The average ejection fraction was 53%. This reflects a broad range of EF that was actually represented in the trial between anywhere as low as 40%, but upwards inclusive of patients with very high or even normal ejection fractions. The average blood pressure at baseline was 130, and many individuals had a history of systemic hypertension. The average GFR at baseline was 62. About half of individuals had GFR values that were below 60. Diabetes was present in about 40%, but importantly, dysglycemia was highly prevalent, and prediabetes was in fact seen in another 30 to 35% of individuals. These patients were well treated with background medical therapies, not only targeting heart failure, but also other comorbidities. Loop diuretic use was highly prevalent. Furthermore, patients were commonly treated with an ACE inhibitor or ARB. SGLT2 inhibitor use and GLP-1 receptor agonist use. The evidence base for these therapies evolved during the duration of conduct of Fine Arts Heart Failure, which was a multi-year trial. Overall, about 13% of individuals were treated at baseline with an SGLT2 inhibitor.
So it really, hearing those baseline characteristics really clarifies that this trial is broadly applicable to the patients that both you and I see as a specialist and as a primary care physician. What were the results of the trial?
So during 2.6 years of median follow-up, finerenone reduced the primary endpoint, again, of cardiovascular death or total worsening heart failure events by 16% with a rate ratio of 0.84. This was highly statistically significant and led to an absolute rate reduction of 2.8 per 100 patient years. This translated to a number needed to treat of between 30 and 35 per 100 patient years. So we felt that these data were definitive and led to clinically meaningful and statistically significant improvements in the primary outcome. There were also improvements in key secondary outcomes, including total worsening heart failure events alone, and improvements in patient-reported outcomes, symptom burden, as assessed by a validated health instrument called the Kansas City Cardiomyopathy Questionnaire. The overall safety profile was in keeping with the preceding chronic kidney disease trial populations. Here we saw comparable rates of serious adverse events compared with even a placebo-treated population. There was an expected increase in hyperkalemia or elevated potassium levels, but protection against hypokalemia. There was very few serious hyperkalemia events, those that led to hospitalizations, and importantly, there was no evidence of hyperkalemia leading to death in either study arm.
So those are impressive results and important results. Um, two, let me ask you about subgroup analyses because questions that I often hear come up. Two particular subgroups, those who in the older cohort, people who are, a little bit older, maybe a little more frail. Was there any difference there? And then also by ejection fraction.
Critically important subgroups, and subgroups ultimately help guide the implementation of these therapies in key clinical phenotypes. The effects of finerenone on the primary endpoint was broadly consistent across 17 pre-specified subgroups that included age and left ventricular ejection fraction, as well as background therapy with therapy like an SGLT2 inhibitor. In terms of age, I mentioned the average age was 72. We saw consistency in the benefit above and below that average age, but also when more granularly looking at age, including in that very old age group in which we're sometimes reluctant to use medical therapies because of concerns of polypharmacy. And furthermore, we saw consistency of benefit across the ejection fraction spectrum. This is very important because pre-trials of renin-angiotensin aldosterone system inhibitors have shown some attenuation of benefit at the highest end of the EF spectrum. Here, we don't see such attenuation, and we saw consistency not only across pre-specified categorical variables of ejection fraction, but also when looking at ejection fraction continuously.
Wow. And so it really seems, the level of effect here is in a similar range, if I remember correctly, to the DELIVER trial with dapagliflozin, where there was about an 18% decrease in the primary endpoint over around the same amount of time, 2.3 years. So this really has a similar level of effect. And interestingly, as you pointed out, works through a completely different mechanism. What do you see as the implications for clinical practice?
I couldn't agree more. I feel that this was a definitive trial in terms of delivering a clinically relevant and statistically significant effect on primary and key secondary endpoints and broadly consistent across major subgroups. Importantly, about 800 individuals were treated at baseline, about 13% were treated at baseline with an SGLT2 inhibitor. We saw that the clinical effects of this therapy was consistent irrespective of baseline use of an SGLT2 inhibitor. So we anticipate the combined use of these therapies would provide additive benefits in terms of this target population. So my view is that I anticipate that finerenone will join SGLT2 inhibitors as foundational classes of therapies for heart failure with mildly reduced or preserved ejection fraction. Both of these therapies provide complementary effects on key disease pathways, appear to have additive benefits on key outcomes, and may even provide synergistic properties in terms of allowing for safe continuation of both therapies, as SGLT2 inhibitors have been shown to attenuate risks of hyperkalemia when used in combination with an MRA. So in my view, finerenone should join SGLT2 inhibitors as standard of care population.
What important information. Dr. Muthu Vadiganathan, thank you so much for joining us.
I really appreciate it. I really enjoyed our discussion.
Our article is from Diabetes Care, and it looked at comprehensive multiple risk factor controlled type 2 diabetes to mitigate heart failure risk, insights from a prospective cohort study. So this prospective study included close to 12,000 individuals diagnosed with type 2 diabetes who were matched with close to 48,000 non-type 2 control study participants who were in the UK Biobank cohort. The degree of comprehensive risk factor control was assessed on the basis of the major cardiovascular risk factors. They included blood pressure, BMI, LDL cholesterol, A1C, renal function, smoking, diet, and physical activity. Cox proportional hazard models were used to measure the associations between the degree of risk factor control and heart failure risks. So the study went on for a median follow-up of 12.3 years per patient. 702 individuals, or 5.87, with type 2 diabetes, and 14,000 matched control participants, 2.93, developed heart failure. Each additional risk factor controlled was associated with an average 19% lower risk of heart failure. Optimal control of at least 6 risk factors was associated with a 67% lower heart failure risk, so a hazard ratio of 0.33. BMI was the primary attributable risk factor for heart failure. Notably, excess risk of heart failure associated with type 2 diabetes could be attenuated to levels comparable to those of patients who did not have diabetes. When individuals had a high degree of risk factor control, the hazard ratio also was decreased to 0.66, and they exhibited a longer heart-free survival time. Neil?
John, I love this trial. Just to remind people before we dive in, the stages of heart failure are stage A is at risk. So those are people with diabetes, obesity, prediabetes, hypertension. Stage B is pre-heart failure. That's where someone doesn't have symptoms, but they have structural heart disease, and that can be evidenced by elevated NT-proBNP, diastolic dysfunction on an echo. And then you get to stages C and D, where there's symptomatic heart failure. What I love about this study is it reminds us of the importance of fundamentals, right? And it's easy to forget how important those fundamentals of both risk factor control and lifestyle modification, good diet, good exercise, are. And to see that, and I want to contrast this or compare it to the article that we just talked about, which was an incredibly exciting article, the finerenone fine arts trial that decreased the primary outcome of total heart failure events and death by 16% in people with HFpEF, preserved ejection fraction heart failure. And that is fantastic, and it's important, and it's exciting. But to think that we can actually prevent the development of heart failure by paying attention to all the fundamentals, to paying attention to good blood glucose control, hypertension, and particularly exercise and obesity, is really exciting. It says that what we do every day in the office, taking care of patients, and then what patients do every day at home, taking care of themselves, can make the largest difference in their long-term health. Our next article is from Lancet Diabetes and Endocrinology on the efficacy and safety of once-weekly semaglutide 2.4 milligrams versus placebo in people with obesity and prediabetes. That is the STEP 10 trial. The goal of this trial was to assess the efficacy and safety of semaglutide 2.4 milligrams for weight management and glycemic control in individuals with obesity and prediabetes. It was a randomized, double-blind, parallel group phase 3 trial, multinational, that included participants 18 years and older with a BMI of 30 or greater and prediabetes. Prediabetes was defined according to the UK National Institute for Health and Care Excellence criteria, which was a little different than the criteria in the United States. There, the criteria for prediabetes is an A1C of 6 to 6.4%, or a fasting plasma glucose, which is essentially the same as what we look at here, 100 to 125. Participants were randomly assigned in a 2-to-1 ratio to once weekly sub-Q semaglutide 2.4 milligrams or placebo. Both groups had diet and physical activity counseling for 52 weeks. The primary endpoints were percentage change in body weight and the proportion of participants reverting to normal glycemia that was defined by an A1C less than 6 or a fasting plasma glucose less than 5.5 millimoles per liter, which is essentially less than 100 milligrams per liter. There were 138 participants that were assigned to the semaglutide group, 69 to the placebo group. The baseline age was 53 years. Average body weight was 111 kilos, a BMI of 40, an A1C at baseline of 5.9, and a fasting glucose of 107. And what they found was significantly greater reduction in body weight with semaglutide 2.4 milligrams than with placebo at week 52, and that was approximately 14% versus approximately 3%. And a greater proportion of participants reverted to normal glycemia by week 52 with semaglutide than with placebo, and that was 81% in the semaglutide group versus 14% in the placebo group. John?
So I think a very interesting trial. It harkens back to the diabetes prevention trial, the DPP trial that came out in 2002 in the New England Journal. And in that particular trial, they looked at a similar population and compared them to being in an arm that they were placed on metformin or they were given intensive diet or exercise control. So this trial, really exciting. It took a lot of people who were in the prediabetes group and moved them out of it, probably mostly through considerable weight loss. So pretty exciting. When we think about the numbers of people who would fall into that category, there are about 90 million Americans who fall into a prediabetes category. I think one of the things is, are we going to stick 90 million people on semaglutide? Or even if you said it was only a third of those patients, would you put 30 million people on semaglutide? If that prevents people from ever developing diabetes, it might be worth it as a country. Or do we also harken back to a trial that the two arms of the DPP trial showed that extensive diet and exercise worked better than putting patients on a medication? Certainly, I think this reminds us that if we can stop something from ever happening, a lot of the things that we talk about month over month, we just talked about heart failure complications, right? So if we can prevent diabetes from happening, you prevent a lot of problems from developing. So again, I think this is just one of the other things when looking at these medicines that can lead to considerable weight loss. It really can make a huge difference. The question is, do we completely give up on other ways for people to have weight loss through diet and exercise because we have developed something that's a once a week injection and a little bit easier? There was a weight loss supplement or gym advertisement in the 1980s, and it said if everyone could have a good body, it would come in a bottle. And maybe we've reached that point. Our next article is from Diabetes Care, and it looked at diabetes, prediabetes, and brain aging, the role of a healthy lifestyle. So this study included over 31,000 dementia-free adults from the UK Biobank who were between the ages of 40 and 70 years of age. They assessed patients' glycemic status as being normoglycemic, prediabetes, or diabetes, and that was ascertained based on medical history, medication use, A1C that was measured at baseline. Information on cardiometabolic risk factors, obesity, hypertension, low HDL, and high triglycerides, and lifestyle behavior, smoking, drinking, and physical activity was also collected at baseline. The participants underwent up to 2 brain MRIs over 11 years of follow-up. The brain age was estimated using machine learning model that was based on close to 1,100 brain MRI phenotypes to calculate brain age gap, which would be your brain age minus your chronologic age. So at baseline, 13,518 participants had prediabetes and 1,149 had diabetes. Prediabetes and diabetes were both associated with a significantly higher brain age gap, and diabetes was further associated with a significant increase in brain age gap over time. Ultimately, they found out that prediabetes, the brain age gap was about 0.5 years. Diabetes with an A1C under 7, 1.7 years. Diabetes with an A1C 7 to 8, 2.5 years. And an A1C greater than 8, a brain age gap of 4.2 years. Neil?
John, this we've talked before about the relationship between diabetes and Alzheimer's disease, dementia in general, both through its effect on Alzheimer's, where sometimes diabetes has been referred to as type 3 diabetes, and through the effect on multivascular, multi-infarct dementia. It's that part isn't surprising, but the part again that is fascinating is that in the joint exposure analysis, healthy lifestyle, no smoking, no drinking, high physical activity, attenuated that brain age gap. And again, as we talked about earlier, it is about fundamentals. We know that exercise from other articles, which we've also reviewed, can decrease the development of cardiovascular disease in people with diabetes and bring it back almost or all the way to that of someone without diabetes. I think it's exciting to see that the same thing happens here with regard to one of the most feared maladies of older age, dementia, and that things like exercise and risk and other lifestyle interventions make a difference. Our next article is from Diabetes Care and is titled Sitting Time and Its Interaction with Physical Activity in Relation to All-Cause and Heart Disease Mortality in U.S. Adults with Diabetes. And joining us to discuss this article, we are privileged to have one of the authors, Dr. Sandra Albrecht, who is an assistant professor in the Department of Epidemiology and is the co-lead in the Food Systems and Public Health Certificate Program at the Columbia University Mailman School of Public Health. Sandra, welcome.
Thank you for having me.
Sandra, can you go over the background to this article, why you and your co-authors decided to look at this?
Yeah, so we know that over the past few decades, people have been sitting more and more. And they also, we know from a lot of other studies that sitting, or what we call sedentary time, has been associated with a lot of really bad health outcomes and also with increased mortality. And so, but there are also some studies that show that maybe there are some things that you can do to offset that higher mortality. So, namely, doing some exercise when you have a free moment. So what we wanted to do is to see if this pattern also applies among people with diabetes. We know that people with diabetes often have a lot of other comorbid conditions. They're generally at higher risk of mortality. And so we weren't sure if we would see sort of this beneficial impact of higher physical activity against, as protective of mortality in this population. So what we wanted to do first see, is there higher mortality with longer sitting time among people with diabetes? And then secondly, can higher levels of physical activity offset that higher risk of mortality?
And these are critically important questions for all of us as we live in this world where, like you and I are doing, we're sitting right now talking over Zoom. How did you go about looking at this?
Yeah, so we worked with a publicly available data set. So we looked at NHANES. Probably a lot of the listeners might be familiar with it, but for those that are not, it's a National Health and Nutrition Examination Survey. So it's a series of cross-sectional national surveys done in the US of the non-institutionalized population. So we looked at adults with diabetes and NHANES. And then we looked at several, the participants answered questions around how often they engage in physical activity. They used pretty standard questionnaires to answer those questions. They also responded to questions about around, on average, how long they spent sitting per day. So we merged these data with mortality statistics. So we follow the individuals in NHANES over time. We gather the mortality data, and then we evaluated our research questions using these data.
Which leads us to the most important part of our discussion. What does show?
So, as a first step, we showed that sitting for longer periods of time, so in other words, sitting for 8 hours or more per day, which is a standard working day for most Americans, a 9 to 5 type of schedule. So, sitting for 8 hours or more a day was associated with higher mortality among individuals with diabetes. So, higher all cause mortality and higher heart disease mortality. But then we wanted to assess, if people, among the people who sat for a long period of time, if they engaged in a lot of physical activity, can they offset that higher mortality risk? And really, the long story short of it is that yes, they can. So, and basically what we saw is that, again, if you sit for a longer period of time, for 8 hours or more, you have a higher mortality risk. But if you also engaged in high levels of physical activity, and our definition of high levels of physical activity are an average of 150 minutes per week or more. So if they engage in that level of physical activity, they were able to lower their mortality risk.
And so that's pretty important. And I just want to clarify because you really had different, I guess, grades of physical activity. And where you saw the benefit, you really did have to achieve that 150 minutes or more, right? Like 80 minutes wasn't enough. Is that correct?
Exactly, that's right. And so, you know, I think we would have liked to see that any kind of physical activity would help offset that higher mortality risk of sitting time, but it did not in our study. You really had to engage in the sort of meeting the recommended guidelines of physical activity, so that high level of 150 minutes per week or more. And it's those levels of physical activity that were able to offset a high mortality risk if you happen to sit for long periods of time during the day.
Now, I have all sorts of thoughts here, but I'll let you go first.
Mhm.
Clinical implications.
Yeah. So, I mean, obviously, like on the one hand, if a clinician has a patient in front of them, they have to, the first recommendation would be to try to reduce that sitting times, right? So try to stand more, especially if you have the type of job that requires being in an office or at a desk. Try to take lots of breaks, those sorts of things. So we really want to kind of hit at the sort of that main, problem, which is the sitting time piece of it. But if that's not possible, and that's often not possible for lots of other types of jobs, if you're a truck driver, something else where you have to really sit for a long period of time, and it's really hard to not do that. Then, another recommendation is try to find that time at the end of the day, maybe at the beginning of the day, middle of the day, something to sort of engage in that vigorous physical activity. So, going to the gym, going for a run, just doing something vigorous. And it doesn't have to be for a long period of time, because the guidelines for physical activity include sort of moderate to vigorous physical activity, so you can do shorter periods of time but more intense levels of physical activity if you don't have the time. And so recommending those high levels of physical activity, especially for those that have to sit for a long period of time, is really the way to go. But I also do want to kind of throw in a little bit of this caveat too, because as a public health practitioner myself, I'm always, hesitant about only sort of telling people that this is what they need to do, right? Oftentimes people know they know they need to exercise more. I don't think this is, big rocket science to most Americans, right? It's really that it's hard to do. We live in environments that make it very hard to exercise. People don't have time, they don't have the money. And so I think finding a way to kind of bring in resources to help people find ways to engage in physical activity is sort of another step that we can take to help people, along this path.
It's interesting. We come at this from these complementary perspectives, a public health perspective, as you said, and then as an individual clinician. And I used to think that 150 minutes a week is so much until I broke it down. And I realized now when I talk to patients, and this gives me more ammunition and more desire to really address the issue. But this is actually if you can take a 10-minute walk in the morning before going to work, and maybe a 5 or 10 minute walk during lunchtime, and the same at night, which is a beautiful thing to do. If you live with someone, you go with your partner for a little 10 or 15 minute walk after dinner. We actually covered other articles that were in Diabetes Care that showed even mild amount of exercise after eating dampens the rise in blood sugar after eating. And so there are so many benefits. And the strategy for me at the clinician level is to talk with my patients. I can raise the questions, they have the answers. I can raise the why, they have to answer the how. But to together think about concrete strategies about how to accomplish this very important goal. This was really fantastic data that I think is actionable information.
Yeah, no, I appreciate it. And that's what we're hoping for too. And again, we don't want to go to this sort of telling people to exercise without giving them some more information about how best to implement these guidelines in their lives. So really getting to know about what are some of the constraints are and then giving them some creative ideas. Like you're saying, walking in the morning or doing some exercise after work or in the middle of the day, just finding some other ways to help them engage in physical activity, given their life constraints, is, I think, a really good way to go.
Dr. Sandra Albrecht, thank you so much for joining us.
Thank you for having me.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.